Lots of people coming in, that's really good. If you're already in the meeting, can you make sure that your camera is off and your microphone is off? I should have muted you all, but just in case, if you check that your microphones and camera are all off, and then we won't all get in each other's way. So we have 70 participants at the moment, and nobody else currently in the waiting room. So let's see how we go. So good evening, everybody. My name is Cathy Yelf, and I'm the Chief Executive of the Macular Society, and a very warm welcome to our virtual meeting today. I'm admitting more people as we speak. This is the first of the Macular Society's virtual clinics. This is something that we've decided to do because, quite frankly, we've missed you. We've missed you at the events that we normally hold throughout the year and around the country. And we're missing you. So we're hoping that these virtual clinics are going to be a way for us to keep in contact, and particularly for us to help you keep in touch with macular matters and to give you continued access, to continue to be able to give you access to some of the people who are at the very top of the macular business. And that's what these clinics are all about, bringing you some of the world-leading experts on all things macular. So we're on for about an hour. As I say, if you haven't muted yourself or shut off your camera, please do so now. And during the session, you can ask questions. You can do that by the chat mechanism, and we'll be monitoring those questions, and we'll try to get through as many of them as we possibly can through the session. We'll also be hoping to do these for a long time, these sessions, and we want to make them as good as they possibly can be. So afterwards, we'll be sending you some feedback forms, and we'd be really appreciative if you could give us your feedback if possible, so that we can really improve these as we go along and make them as useful and enjoyable as we possibly can. So I'm going to introduce tonight's guest. Our very first guest tonight is Robin Hamilton. Robin is a consultant ophthalmologist at Moorfields Hospital in London. Moorfields, of course, is one of the finest, if not the finest, eye hospital in the world. And Robin is the director of the medical retina service at Moorfields. So I'm going to hand over to Robin and ask him if he would then pick up tonight and tell us a little bit about how clinics have been adapting to coronavirus. It's had an enormous impact, as I'm sure many of you will know, on the way in which clinics can deal with coronavirus as well as treating patients. And it's not just really a short-term problem, it is going to be a long-standing problem for eye clinics and for patients who go to eye clinics. So, Robin, I'm going to hand over to you, if I may now. Welcome, and thank you very much indeed for joining us this evening. Robin Hamilton.
Cathy, thanks very much for the introduction, and it's a pleasure to be speaking to everybody this evening. I did have some slides to share, but probably don't really need them. I think Rita's currently got her slide on the screen, but frankly, I don't really need the slides. So what I thought it would be appropriate to discuss is the whole different range, really, of what has happened, what is happening, what the future holds, and probably look at it from a number of different angles, because I think a lot of you have been affected either directly or indirectly by COVID, and probably a lot of your eye treatments or access to eye hospitals or even any other hospital has been affected by what has happened since March. What I thought I would go through is just a few little reminders on the COVID timelines, what the government did, a little bit on shielding at-risk patients, hospital responses, what we did within the college and the service, and how things have changed in the hospital with their protocols and pathways, and a number of different steps that have appeared, possibly because you could argue as an opportunity when people started to think of different ways of working. Some patients have not needed access to hospital and maybe in some instances community care is potentially better. So I think if we start right at the beginning, 16th of March, I think some of you will probably recall, was when Matt Hancock advised no unnecessary social contact. And that's when it really all started. It took a week before Boris said anything to us. And that's when he said that people must stay at home and certain businesses must close. And really this is what kick-started everything, and all the concern, worries, illnesses. Sadly, a lot of us have had colleagues or friends or family pass away due to this horrible virus. And at this time also, there are a lot of people who are very concerned regarding their own health, not only those people coming into hospital, but the people actually in hospital. The government put in a lot of steps to say, listen, there are some people who are more at risk than others, so you're the vulnerable, and there are some who were just simply at much higher risk. And maybe we could go through some of that a little bit later on. But of course, if you were higher risk, you had to shield. And there are some people who are still shielding. And so the government and the NHS described clinically extremely vulnerable. So this was expert doctors in England who identified specific medical conditions based on what was known about the virus in China and other parts. I seem to have lost you.
Robin, we've got you on screen now, so I think you'll be able to share your screen, I hope.
You still there?
Yes, we're all here.
Good, sorry. I lost the screen there for some reason. So this was based on what was known about the virus from China, slightly what was known about the virus from Italy. And there were some people who were designated at greatest risk of severe illness. And those were patients who had solid organ transplants, some people who had specific cancers and chemotherapy, radiotherapy, blood-borne or bone marrow cancer. That kind of thing. I think it might be appropriate for everyone else to mute unless I say something that I really shouldn't say, and in which case please do stop me. So other people who had bone marrow stem cell transplants, that sort of thing, and anyone who was taking immunosuppressive drugs, those with severe respiratory conditions, and other things like immunodeficiencies or immune suppression, heart disease, and things like that. So those were the patients who were deemed extremely vulnerable and should shield. And there are a reasonable number of those, and those patients are still shielding to a certain extent and not coming into the trust at the moment. We were seeing a lot of these patients in our uveitis service, a lot of people on immunosuppression, and a lot of care was taken, and we actually designated a specific part of the hospital for the patients who fitted that particular group, just to keep everybody away from the rest of the hospital population. There was another group which really affected most of my service, which were those who were deemed moderate risk and clinically vulnerable. And essentially that was anybody over 70, anyone who had lung conditions such as asthma, COPD, bronchitis, heart disease such as heart failure, anyone who was diabetic, chronic kidney disease, liver disease, any brain or motor neuron disease, Parkinson's, that sort of thing. And with time, what we started to find out also is there were other groups who were slightly more at risk, so the black and minority ethnics, or the BAME group, anybody who had a BMI over 40, and indeed potentially anybody who was pregnant. So this was a group which, particularly for my service with diabetes and macular degeneration, anyone with macular disease, even those with vein occlusions and things, that really was the biggest group that was going to affect my service and all of you, potentially. So there were various things that were put in place within the trust. We at Moorfields had a lot of dialogue with the Royal College of Ophthalmologists. We produced a risk stratification to try and keep only those at highest risk of visual loss, and really to treat all those patients who were potentially at risk of irreversible and preventable sight loss. Now, one could argue that if you had a cataract, probably you could wait. If there was a little bit of diabetic macular edema, again, you could wait, particularly if you were if you balance the risk of diabetes and catching COVID. But we felt it appropriate that those patients who would get irreversible and preventable sight loss, if they weren't treated, should come into the trust. So that meant anyone with age-related macular degeneration, in fact, anyone with a choroidal neovascular membrane for any particular disease, be it age-related macular degeneration or myopia or inflammatory disease of the retina. Patients who had central retinal vein occlusions, proliferative diabetic retinopathy, all of those we wanted to see on a regular basis. Anybody who had who needed surgery, so retinal detachments, a lot of our oncology patients continued to come. Again, you have to balance risk versus benefit in all of those too. So those were the main high risk, and we did continue to do a lot of injections. So at Moorfields, we continued to do 2,000 injections on a monthly basis. And I'll get to a little bit of the other bits and pieces that happened later, which made that quite difficult and challenging, but we'll get to that in a bit. There are other parts to the risk stratification, as I mentioned. So you had medium risk, and so these patients were delayed for anything from 3 to 4 months. As it turns out, it's probably more than 3 to 4 months now, as we're just beginning to get our patients back over the last 3 or 4 weeks. And there are also those patients with fairly low risk who we felt could be delayed for 6 months. And that was a reasonable number within the trust, which meant that we could really feel that the patients that were coming into the trust and were being treated could do so safely. With appropriate social distancing. We could clean the instruments, we could clean the rooms, we could make sure that we had enough of our masks and things, and so that we felt that anyone who was coming was safe. Have to remember also that we needed not only to prevent patients from catching anything from other patients who were coming in, but they had to prevent patients catching anything from staff. And finally, also staff. At the time, there were a number of staff who were also deemed high risk and extremely vulnerable. So a lot of those we had to ask to stay out of the hospital. And any members of staff who did get any temperature or anything had to isolate initially for 14 days. And if any member of staff's family had a temperature, again, that member of staff had to isolate for 14 days. This was all prior to the testing that we are now receiving on a weekly basis. We lost 3 members of staff within the first month at Moorfields, which was devastating. 1 consultant colleague of mine in the retina service down at Croydon, and 2 other members of staff, 1 nurse and 1 of our estates team, which was devastating. And it really hit home quite hard for the staff, and we really made every effort to make sure that everybody within the hospital stayed as safe as possible. I mentioned the masks and things, and all the personal protective equipment that was slow to come to the trust and slow to come to everybody. The supply lines were limited. We've all read the news, and the delivery to the NHS frontline was not quite what we had hoped, but we all started to get these face masks, the visors, gloves, and aprons to make sure that we were all safe. We changed before we started seeing patients on the front line, so we're all in our theatre scrubs, and different kinds of filtering face masks, these FFPs. we used at different times. So in theatre, you often had to use a very a tight face mask to make sure that there was nothing that came either to the surgeon or to the patient whilst in close proximity. Similarly, whilst doing lasers. And of course, doing injections, very important that our staff are wearing masks as well as now our patients do. So getting the personal protective equipment made us all feel a lot safer. I hope it made all of you feel a lot safer if any of you were coming to the hospital. But it certainly felt us feel safer, and also made us feel as though there was less chance of us giving COVID if we were asymptomatic to any of our patients. So as I said, more fields were involved with the college for risk stratification, working out who should and shouldn't come to hospital in multiple different areas of ophthalmology. And of course, retina, which I was most impacted in. I watched this very closely because a lot of hospitals in and around London were closing because they didn't feel as though they were safe enough. A lot of the hospitals became red sites, so they were COVID active sites. And a lot of my colleagues around not only Moorfields but around London gave up ophthalmology to go and work in places like the Excel Nightingale. But also they were sent to other wards within the different trusts. So some worked in ITU, some worked in casualty, some worked in the respiratory teams, or as I say, ITU or special dependency units. And 3 or 4 of the units around us in the southwest and in the east closed completely to all ophthalmology. Now, some of you may have been affected by that. So as the largest hospital in London, we felt it was our duty to make sure we stayed as open as possible and saw as many patients as we possibly could. We did have 9 injection sites initially open around London. That had to reduce to 5 within the first month. And that was due to guidance from North Central, Northwest, Southwest, Northeast London. So that was put upon us. We had no choice. There was also a distinct possibility that we could have potentially been reduced to 1 site only, which would have meant all our patients travelling to the 1 site in City Road. We fought very hard against this and managed to keep 5 sites open, but that still left a lot of vulnerable people without a local service to be treated. And appreciated that was not only our trust, but there were multiple trusts across the country and across London. At the time of COVID in March, we had over 3,300 patients with macular degeneration being treated within the trust. The number of injection patients essentially was double that if you include diabetics, vein occlusions, myopia, inflammatory, etc. So a significant number of patients. We really felt it imperative to make sure we kept hold of our central retinal vein occlusion patients and our macular degeneration patients. We were also mindful that at the time, 89% of our macular degeneration patients were over the age of 70 and therefore vulnerable, and 72% were over the age of 80 and significantly vulnerable. So it was a worrying time for all of us. But as I say, we managed to maintain 2,000 injections on a monthly basis. But we had to change the way we did and we ran our injection program. So our pathway had to change. And again, as I mentioned before, the real reason to change the pathway was to reduce the face-to-face contact, reduce patient time within the hospital, patient-to-patient contact, and potentially we reduced the risk of travel to and from hospital. Anybody who was on the tube in April and May would have noticed it was completely empty, but that doesn't mean to say that you weren't at risk of catching something on the tube or the train or the bus. So when we decided to change our pathway, what we did is we felt, actually, let's try and get our patients in and out as quickly as possible. So We didn't do any visual acuities, we didn't do any OCTs, no slit lamp review, so again, not having patients in close contact with the medical staff. And we maintained the injection frequency from previous visits. So if, for example, if you're on a 4-weekly cycle, you stayed on that. If you're on an 8-weekly cycle, you stayed on that. And this was really designed to get as many treatments done as possible in the safest environment as possible. We were concerned that patients would lose vision if we did change to this particular pathway. And we are examining our patients now as we have reverted back to almost our standard pathway now, although we still only are now 6 sites open for injections. But we are now seeing whether we have caused any harm. And at present, we don't feel as though we have caused significant harm to any of our patients, but I'm sure there will be a couple who sadly may have lost some vision. I think it'll be those patients who have shielded and have found it impossible to get into hospital in any safe means. I suppose one other piece of background, just to remind people, is if you catch COVID in hospital, that was much more likely that you were going to catch it more severely and less likely to survive it. And that was at the top of our minds when we did all of these changes. And we were also particularly concerned that any patients in care homes, if they came to the trust and picked up COVID and then took it back to their care home, that was potentially devastating. And I don't think you can underestimate the baseline anxiety. I'm sure you have all had it, but I don't think you can underestimate the baseline anxiety of sitting in front of a patient, not knowing whether they have COVID and not knowing whether you have COVID, and trying to have a discussion, be it as short as possible, in order to make that potential risk, the unknown risk, reduced as much as possible. Now, these are the things that we did. What we also were mindful of is what all our patients and the community were doing. So we have been monitoring all avenues of access to the hospital, and we know that the ophthalmic A&E visits at Moorfields were down 80%. And that's really people voting with their feet and saying, listen, I don't think this is a big enough problem for me to come in, so I'm not. What Moorfields were very active in doing, however, was they created a pathway for virtual visits with either telephone and video conferencing. And some of you may have tried this. The Attend Anywhere software on mobile phones and computers allows you to access an ophthalmologist who will be sitting in or next to your eye casualty and give you detail or advice on what you should be doing, either via telephone or video conferencing. And we found that really helped in a lot of instances. From a macular degeneration point of view, I think I was particularly concerned because optometry practices were not open. Now, optometry practice is usually the first port of call. If you lose vision or you feel you're losing vision, you go to an optometry practice first, they give you a potential diagnosis, and then you come up to A&E or to the clinic. And so we were monitoring our macular degeneration cases and comparing early April and early May to a year previously. We dropped to approximately 15% of what we would normally see. So our new cases of macular degeneration dropped by 15%. And across the UK, it was the same, not quite as bad as, or not quite as affected as us, I would say. And in the UK, there was a drop of 3/4, so only 25% of new AMD cases were attending. They're beginning to filter through now, but again, a lot of people are still shielding and isolating, which I fully understand. But there is a big concern that there may be a number of patients out there who have lost some vision. It's not just macular degeneration. We've noted that retinal detachment attendances have dropped by 2/3 over the same time period, which again is very worrying. Macular degeneration will affect your central vision, whereas a retinal detachment, if left untreated, you would potentially lose your eye completely. So a big concern for everybody. And I do hope we can start to see some of our patients back in a slightly more normal atmosphere. To look a little bit on the bright side, what this has done is it has given a number of people an opportunity to think of how to deliver eye services potentially better and in a different way. So up in Manchester, and it's now being moved around the country, there was a queues service which is set up, which is called the COVID-19 Urgent Eye Care Service, which was developed by NHS England and the local LOXU, and endorsed by the College of Optometrists and the College of Ophthalmology. And we've been involved in this in Moorfields in southwest London, and looking to expand it into north central London as well. And essentially, this is via primary care optometrists. So there are some optometrists who were encouraged to stay open and see urgent cases only, not dispensing glasses, because potentially dispensing glasses means you have patients picking up glasses, putting them down, picking up another one, putting them down. It's the easiest way to spread COVID from an ophthalmology point of view. The people who have concerns regarding their eye care could visit primary care optometrists supported by hospital eye services. And with the network of optometry practices, one could potentially deal with a lot of these situations remotely. And we know if we can get detail from optometrists to the local eye services in the form of visual acuities, letters, and in particular OCT scans, and the full OCT scan, so it can be reviewed and potentially compared to previous OCT scans, then we do feel that potentially even up to 3/4 of patients may well be able to be managed just by an optometry visit. So if we can reduce a large number of unnecessary visits to hospital, that has to be a good thing. So I applaud those who started this up in Manchester, and I'm encouraging my team, and indeed I'm getting involved in this in London. And in the long run, I do hope that this is something that would be a little sort of light at the end of the tunnel in a pretty bleak last 4 to 5 months. So again, this may reduce ophthalmology attendances. It may also reduce GP attendances. Could release hospital workforce for other more complex ophthalmic care, allow us to do more in-depth work, and always reducing the COVID-19 infection. Reduce patient travel, reduce face-to-face contact time. It's going to be safe access for patients, improve quality of referrals, lower risk. All these things I've said already. Anything that was going to help reduce the risk of infection, reduce the need for multiple trips, travel, multiple face-to-face, multiple contact time has got to be a good thing. And I think, the A&E thing as well, which does worry me somewhat, has not just been seen in Moorfields, but it's been seen across the whole of the NHS, with a significant reduction in all A&E visits. And again, it's probably down by 2/3 across most of the UK, be it A&E or ophthalmic A&E. One other, again, potential light at the end of the tunnel, which we're working really hard on, is trying to improve home monitoring. Now, a lot of you will have seen the traditional AMSLA grids, and they are still excellent, provided you're using the right ones. But they are still excellent. I encourage you to continue to use those. But there are a lot of other ones that are now appearing on computers, iPads, and phones that allow you to assess your vision, your distortion, your color vision at home. And we're trialing 3 different types of Moorfields to validate them for their effectivity. And again, if this can highlight either pathology which is happening or reassure you that there is no pathology happening and you do not need to make a visit to the hospital, then that, again, would be a really good thing. Anything that keeps patients out of A&E unless they have to have any significant issues has got to be a good thing. But obviously, anything that picks up something which could potentially be a significant pathology would be well worth having. So that's the other piece of potentially good news. And finally, I just wanted to touch on what is happening now. So In my trust and in most other trusts, the surgery has restarted. So cataract surgery, I was operating all day today on cataracts. So that has kicked back off. But we have to remind ourselves that we're 5 months behind. Moorfields does 30,000 cataracts on a yearly basis, so that's about 12,000 cataracts behind. We will endeavour to catch up with weekend, evening working and opening other cataract sites. In north central London, Moorfields are leading a lot of the recovery, which will include the Royal Free and Barnet. How exactly that is going to look is unclear at the moment. Also acutely aware that in the medical retina service in particular, which is my service, we are somewhere in the region of 40,000 outpatient appointments behind, which is a staggering number if you think about it. So we will be building what we call diagnostic hubs in order to, again, try and work out how to get our most important patients, should say our most at-risk patients into the hospital, and see if there are some patients who we can maintain in a virtual, stable, less face-to-face waiting time appointment scenario. So that is what we're working on in north central London. We are working on that also in southwest London, where Moorfields is the lead for ophthalmology. Northwest London, and I'm sorry I'm being so London specific, but this is my patch, so I know more about it. Northwest London is being led by Imperial. So again, we will see how they deal with the recovery. But there is a lot of work to be done, and potentially not a lot of time to do it in, if there is going to be a second peak. We are, with the virtual diagnostic hubs, building them to be COVID safe. Our cataract pathways, we are also building to be COVID safe. As I mentioned to you earlier, we're all being tested on a weekly basis for antigens, see if we are infective. So everybody in the theatre arena is being tested on a weekly basis. All patients who come into the theatre arena, bar emergencies, are all being tested prior to coming in. We still are checking temperatures on the entrance to hospitals. And I would say in most instances, in most hospitals, these are the kind of steps which are being taken. I attend a number of forums in which we discuss this recovery piece. And I think we are all pretty clear that this is the most appropriate way to do it at the moment. So that is hopefully a reasonably comprehensive run through of where we have got to and how we've got there over the last 5 months. And I do hope that's been helpful, and I'm happy to take any questions.
Robin, thank you very much. That's been a fascinating insight, really. And we know that that patients have been very frightened during this period. It has been a very frightening time. But I think the efforts and the extreme lengths that hospital clinics have been to make sure that patients are safe, often when people have gone, they've reported back how quick and easy it was, and how actually they did feel reassured and quite safe that the measures that had needed to be taken had in fact been taken. So thank you to you and all your colleagues for all that you've done in this. It must have been a very stressful time for everybody, I'm sure.
I think it is.
But it's interesting that, it's an ill wind, they say, that blows nobody any good. And it is interesting that lots of clinics are saying that they are seeing positives that will come out of this long run, and that maybe some of the changes that were happening very slowly in eye clinics are now going to happen a lot quicker, and that in the end will be good for patients. Do you think?
I agree with that completely. I think I tried to mention a couple of positives towards the end there, and that's really just highlighting probably the two main positives, but I think there are going to be a whole host of other things. And I hate to say I'm taking this as an opportunity, but I have to take it as an opportunity to make sure that the service, when it gets back to some form of normality, is much better, much safer. The outcomes are better, the patient experience is better. And I think that, therefore, for me, it's got to be an opportunity, and we've got to take it as that.
Absolutely, I'm sure that's right. We've had some questions in, Robin, so I wonder if I can throw a few questions at you quickly.
Sure.
A couple of people have have mentioned this week there's a new implant that's been developed by Roche, which is intended, it's a port, what they call it, a port delivery system, which is intended to allow the anti-VEGF drugs for wet AMD to last longer in the eye. I think that's the idea of it. Can you tell us just a couple of minutes about that, and when you think it might be, when it's going to hove into view?
You know, with all of these things, I'd like them yesterday, to be honest with you. But there's always a process. So the port delivery system, or the PDS, is something that has been trialed in various different phases across the world for quite a few years now. And Roche have been pushing it. Obviously, Roche have had to create a deal with Genentech in the US and Novartis now in Europe to put the Lucentis and the different, it's actually not the Lucentis that we know it, it's a slightly different formulation, but essentially put Lucentis into the port delivery system. And essentially what this is it's like, it's almost like a little grain of rice, probably even smaller than that, to be honest with you, which just sits in the same area that you would normally do your injections. So it goes through the pars plana, which is about 3.54 millimeters back from the corneosteal junction. It just sits deep to that. And potentially what you can do is you can refill it as and when necessary. Needs at the moment to be implanted by a vitreoretinal surgeon, excuse me. But it's showed in its phase 3 studies now, which is the one that's recently been published, reported rather, is the Archway study, which is showing that anything up to 6 months is possible with one application. Now, those patients who are coming in on a 4-weekly basis will appreciate that this is a wonderful step, and I'm looking forward to trying it.
Do you know how?
The process? Sorry.
Do you know how patients?
I was just going to say the process. Yeah, so I was going to get to that, Kathy. I think the first one is to say, when is it going to come to us? So the first thing to say is what happens when you finish your phase 3 studies is the company, which was Roche, would then make an application to NICE for a review. The NICE would then plan a review based on the clinical data. After the review, it would then potentially come to the NHS. What NICE tend to do is they would also look at the patients who have gone on to the study and make a decision as to which patient groups would be appropriate and which patient groups would be cost effective. Now, potentially that could be anybody with macular degeneration. And I think we have to think about macular degeneration at the moment because that's where the study took place. But it potentially could be used in all other disease entities which require anti-VEGF, such as Lucentis. I suppose another question that a lot of people ask is, why Lucentis? Why not one of the other drugs? I think the port delivery system is designed to take any drug, but obviously pharma may have a concern about using one particular drug, and for example, Bayer may not be interested in the port delivery system being introduced by a competitor. We've got to also remember that Roche have their own drug in the pipeline, so it's very possible that Roche will move away from Lucentis for further phase 3 studies and start to use their own drug, which again would be great from my point of view. The more drugs and the more availability there is on the market, the more competition there is, means better access. It means also that it then becomes cheaper and easier for the NHS to access. But I don't think the port delivery system is the only thing that we need to be looking out for in the future. As I said, there are other drugs from Roche. Novartis have another drug, which is brolucizumab, which will have to go through NICE at some point in the near future. So there are others coming to the market and other potential things coming to the market, which I'm very excited about. The less injections, the less treatments that our patients will have to receive, the better.
That's great. That's really good news. There is such a lot happening in AMD now, isn't there? There is a lot happening in the field. A couple of people have asked about cataracts. So this is a very big question. And it's interesting, you're doing cataracts all day today. People with wet AMD or with other eye conditions, uveitis, macular cyst, macular hole, if they're told they need a cataract operation as well, they're worried whether that's a good thing or not. What is the view now on cataract with other macular or retinal conditions at the same time?
Yeah, I think that's a really good question, Kathy. So I think first thing to say is cataract surgery safe in the current environment? And I think most hospitals where cataract surgery are taking place at the moment have now got their cataracts into what we call a green pathway, which means all the surgeons are tested, all the nurses are tested, all the patients are tested, so everybody should be safe. That can never be 100% because some of us travel in on the train or the tube or the bus, and patients travel in the train or tube or the bus, but in theory it should be safe. Going back to where your original question is it safe in a lot of other macular diseases? So cataract surgery in things like macular degeneration, I think that's probably the first one to tackle. In most instances, if you have dry macular degeneration, it does not increase your risk of becoming wet. If you already have wet macular degeneration, does it increase the frequency of your injections, or does it cause reactivation of wet macular degeneration? The answer to that in our audit is no. So there is no good real world or randomized controlled studies which give us a definitive answer. And having looked at all our macular degeneration patients who have had cataract surgery during treatment or after treatment, it does not appear to cause a reactivation. If you stop any of the macular degeneration treatments, you are potentially going to reactivate. Even during your treatment cycle, you could potentially reactivate. But at the moment, cataract surgery does not appear to make anything worse. Other macular diseases, such as epiretinal membrane or macular hole, at present there is no clear data to say that cataract surgery does make it worse. In a lot of instances, it's sometimes worthwhile having the cataract surgery and the macular hole and the epiretinal membrane treatment at the same time. The ones where cataract surgery does potentially make your retina or your macula worse is patients who have had any kind of vascular disease on the retina beforehand. So anybody who is diabetic, anyone who has diabetic retinopathy or diabetic maculopathy, they are at an increased risk. There are measures that you can take to reduce the risk. So a lot of perioperative measures and post-operative measures can reduce the risk. But similarly, anybody who's had a vein occlusion, branch retinal vein occlusion, central retinal vein occlusion, or any other vascular disease, then yes, a cataract operation can make it worse, but there are measures you can take to prevent that.
So overall, on balance, most people would be able to have a cataract operation in spite of their macular condition, do you think? Is that basically the shorthand for that?
Yes.
That's really
yeah.
Thank you. So another question about warfarin. This is sorry, my diary is alerting me to something. Warfarin, if somebody's a patient on warfarin, does that impact the way they receive wet AMD treatment?
In my view, no. Having an INR which is slightly higher or even slightly outside of your therapeutic range should not affect not only your macular disease nor your treatments. So it doesn't make any difference to us at Moorfields whether you're on warfarin, even if you're on any of the other blood thinning agents, the Pixaban and some of the newer agents. It doesn't make any difference. It doesn't clearly make any difference to our treatment regimen. There is a piece of work that has recently started looking at warfarin and how it reacts with vitamins. So there is a potential reaction with vitamins which could put you at risk of developing wet macular degeneration. That has not been proven. I'll say that right at the beginning. It hasn't been proven, so it shouldn't stop you from considering taking warfarin. You shouldn't stop taking warfarin. But it's been a concern just simply because of its mechanism of action. So we don't know, but there is an investigation that is being undertaken to have a look into that.
That's
So
great. Thank you.
it's no problem.
So another question, which might be a little bit too specific, but somebody who's had myopic macular degeneration for a long time, 20 years, but it's been stable for most of that time. But she does now have some scarring, which followed earlier bleeding. And this seems to have got larger. So whether there is some atrophy associated with that, but this person is concerned about how fast, whether this is a fast moving atrophy, if that's what it is, or in other words, how will it progress quickly, this now that it's been stable for quite a long time, but apart from the atrophy, and now she's wondering how long that how quickly that might move and progress.
It's difficult to really go into the specifics because everybody is different. We know that everybody has aging of their retina. By the time you get to 55, 80% of people have some form of aging change on the retina. So by definition, the retina ages, cells die fairly early on. Just as our skin changes, our retina changes. When it comes specifically to do with myopic degeneration, there are two bits to this really. The first one is the myopic degeneration, which gives you a coronal neovascular membrane, which is the same as age-related macular degeneration. Now, in that instance, some things can happen very, very quickly, and you get the sudden distortion and blurring similar to macular degeneration. And in that instance, you need to have regular injections in a similar fashion to your macular degeneration. So that's the first thing, and I would encourage anyone who is myopic, those specifically of significant myopia, to be monitoring your ambulatory grid on a regular basis. The second aspect is your myopic degeneration, your chorioretinal atrophy. And this progresses in different speeds in different people. It progresses very, very quickly. What most patients who have it don't realize is that there is progression fairly slowly, year on year, but only when it starts to affect the area of the retina that you read with do you really then feel it's a problem. So you can get a lot of myopic chorioretinal atrophy in and around your disc, in and around the arcades of your macula. And to be honest with you, you wouldn't know it unless you were having an OCT with fundus autofluorescence on a yearly basis. Only when it hits the fovea and the macula does it become a real problem. But as I say, everybody's different, and it's really hard to stick to specifics. But I would encourage people to see an optometrist on a yearly basis for an OCT, so you could actually monitor it. Sadly, there's not a huge amount you can do about it at the moment. But again, I would encourage you to monitor with an AMSA grid, maintain a healthy diet, vitamin supplementation, non-smoking, controlling blood pressure, etc. Always really valuable in these cases.
Thank you. Vitamin supplementation, and we've had a question about that as well from somebody who had been getting ARIDS formulation on prescription and now can't get it on prescription. And she's wondering whether there is something that we could do or should be doing to try to change that and campaign for to have this back on. It used to be quite common, I think, to have it on prescription, but over the years, more and more commissioners have switched that off, I think.
Yeah, I think again, it's a difficult one because it's a potentially quite costly endeavour. The ARIDS studies were very interesting, and I'll just sort of maybe summarise again a little bit. The ARIDS study 1, which looked at multiple different vitamins, A, C, E, as well as zinc and copper, did show that there was benefit from vitamin supplementation. The real benefits, however, came from the ARIDS 2 study with the lutein and xanthine. And the lutein and xanthine do show very clear benefit. The problem with the ARIDS 2 study is it basically told us if we had a really healthy diet, there was no benefit from vitamin supplementation. So if you're a commissioner or sitting in public health and you say, okay, well, I'll tell you what, why don't we put vitamins on the formulary? It's difficult because the GP may well turn to you and say, well, just have a healthy diet. You don't need vitamins. And there is an argument for that, which, not being in the public health arena, I struggle to fight against, to be honest with you. In my view, I would love it to be on the formulary for everybody and available for everybody. But I can see where the public health group are coming from, and I think we would find it difficult. Although keen to help the fight, I think we would find it difficult to get it on the NHS formulary.
Yes, I think it is going to be a challenge. And I think when NICE developed a clinical guideline for macular degeneration, they declined to recommend vitamin supplementation, which they said was because there was an insufficiency of evidence to show that it was really effective. But I know a lot of people were very disappointed. Another question has come from somebody who said, you mentioned queues, this marvellous initiative to get people through the system, the urgent eye care services. And the question is, how does a person locate one of these urgent eye care hubs? How do patients know where to go if that's what they need to do?
That's a really good question. Manchester have set up a number of different optometrists. Southwest London, we have set up a number of different optometrists as well. Because it's in its infancy in London, I'm unclear exactly how one would access. I think, Kathy, it might be worthwhile you and I getting together after this and just having a word with the College of Ophthalmologists, and just maybe making sure that it's available either on their website or on the Macular Society website, or both, actually. Yeah,
that's great. That's great. Presumably, people can phone clinics still, can't they, and ask? Yes. I suppose, have you got one of these in the area? And if people are genuinely very worried, so I mean, as you say, lots of people haven't been going to A&E for all kinds of health reasons, not just eye health. But if people are genuinely frightened and worried that something is terrible happening to their vision, do they go to A&E still? Is that still what they should do?
Well, for Moorfields, we have this attend anywhere. So essentially, if you phone up the eye casualty, you'll be given a specific appointment where an ophthalmologist will call you either by video or telephone, whichever you would prefer, to discuss your concerns. Now, that's not designed to stop you coming. It's designed to prevent you making unnecessary trip. So for example, if you've got some conjunctivitis and you're on a video conference with someone on Attend Anywhere, you can actually, in most instances, work out by looking at the conjunctiva over phone whether this is bacterial, allergic, or viral. And in that instance, you can coordinate therapy via a pharmacy without a trip up to the hospital. Slightly more difficult in something like macular degeneration. And if you've got sudden onset or blurring or distortion, that kind of a phone call is really not that beneficial. So I would love you to come up to Moorfields Casualty. We have a rapid access through to our medical retina service at the moment. So that's what I would hope you would do. If that is difficult for you, then finding an optometrist who is open, who has an OCT, who has access to us. And at the moment, our optometrists who are open have very quick and easy access to us.
That's marvellous. Somebody, you may have spotted, everybody on the chat, that somebody has responded to the question about queues and got to it via, well, effectively got urgent treatment via the GP who sent them to have an urgent appointment with an optometrist, which is marvellous. That's really what we want to do. So that's jolly good. And possibly call 111. Would they be able to, would the NHS know about queues? NHS 111 know about queues and direct people, do you think?
I think, honestly, I think that is unlikely at the moment. I think if you're in Manchester, if it gets put through to the Manchester, or if you're in Southwest London, George's Croydon, then yes, they may well know. It is the kind of thing which is really making the headlines, and as it's been pushed or produced in conjunction with NHS England, then it would be in NHS England's benefit to have it on the 111 line. So I would expect, if they haven't got it already, then they will at some point.
That's terrific. Thank you very much indeed. Well, Robin, we're coming towards the end of this session, and I can't thank you enough for dashing home from a day of cataract surgery on a no doubt very hot and sweaty train.
Pretty hot.
And managing to join us this evening. It's really kind of generous of you to give us so much of your time, and I'm truly, truly grateful. Thank you also to everybody for all the questions this evening, which I think were really helpful in everybody understanding a bit more about it. So this is the end of the first virtual clinic of the Macular Society, but we will have another one next month on again the second Tuesday, so it will be the 8th of September at 7 o'clock. And our guest on that occasion will be Miss Claire Bailey, Dr. Claire Bailey, who is a very senior consultant ophthalmologist from Bristol. And she will be talking about dry AMD and some of the potential for treatment for dry AMD that is coming down the pipeline soon, we hope. But I hope to see you then. In the meantime, thank you all very much indeed for joining us this evening. And Robin, thank you again very much indeed for joining us too. Good night, everybody, and stay safe, as we say. Good night.
Pleasure. Bye for now.